Okay, our presentation is on dwarfism. So, dwarfism is classified as a skeletal dysplasia, a group of over 400 conditions affecting bone and cartilage development. The hallmark feature is short stature, with adults typically under 4'10". Most forms are genetic and are often diagnosed in childhood or even prenatally through imaging or genetic testing. It is not a single disorder, but a spectrum of conditions that vary in cause and severity. In pediatrics, focus is placed on presentation, diagnosis, and supportive care to promote growth and development. Types of dwarfism. From a pediatric perspective, dwarfism includes several distinct types, each with unique causes and outcomes. The first one is achondroplasia, which is the most common type. It's caused by the FGFR3 mutation. And some features of this type is short limbs, long torso, a prominent forehead with normal intelligence and lifespan. The second type is hypochondroplasia, which is a more mild form of the first one. Some characteristics is mild disproportion, and it is often diagnosed later in childhood. Third one is pituitary dwarfism, which is growth hormone deficiency. And it happens due to low growth hormone, and you have a proportionate short stature. And with the early diagnosis and growth hormone therapy, you can improve your outcome, or patients can improve their outcome of that type of dwarfism. Fourth one is primordial dwarfism. It's rare, it begins before birth, and people have a severe proportionate short stature, delicate bones, microcephaly, and it includes subtypes like Seckle and Russell Silver. The fifth one is thanatophoric dwarfism. It's severe and it's often fatal in infancy. It's characterized by having very short limbs, a narrow chest, underdeveloped lungs, and prenatal diagnosis is possible.
Signs and symptoms. The most common form of disproportionate dwarfism is achondroplasia. These key features include a large head with a prominent forehead, flattened nasal bridge, short arms and thighs, and limited elbow movement. Additional findings may consist of short fingers, bowed legs, and spinal curvature. In contrast, primordial dwarfism is a type of proportionate dwarfism characterized by a smaller head, prominent eyes and nose, and often small or missing teeth. These physical features help differentiate between the types of dwarfism and are important for diagnosis. Medications. One of the newer treatments for achondroplasia is boceprevir, which is a CNP analog. Boceprevir works by stimulating cartilage cell growth, which leads to increased bone growth. This medication is primarily used in children with achondroplasia to help increase linear growth, particularly in the arms and legs, where growth is the most restricted. It represents a significant advancement in the management of achondroplasia, since most past treatments focused only on supportive care rather than promoting growth.
Labs for dwarfism is growth hormone stimulation test, insulin-like growth factor, thyroid function tests, T4 and TCH, karyotype analysis for Turner syndromes for females. The diagnostic testing, we have x-rays for long bones, check for bone age and growth plates, development, MRI and CT of the pituitary gland to rule out tumors or any structural abnormalities. Bone age study, left hand, wrist to see if there's any delayed in growth hormone deficiency.
And here's some nursing interventions. One is to maintain airway and respiratory function, assess for signs of sleep apnea, such as snoring, restlessness, or daytime fatigue, and monitor for frequent ear infections due to small ear canals and eustachian tube dysfunction. Another is to monitor growth and development. Monitor their height, weight, and growth charts regularly, and encourage participation in age-appropriate activities that support independence and self-esteem. Another intervention is to care for their musculoskeletal system, such as monitoring for spinal problems, assess for joint pain or limited mobility, and encourage use of supportive seating, adapted devices, or physical therapy as needed. Lastly, or give them psychological support. Encourage positive body image and coping strategies, offer resources for counseling or support groups, and educate peers and school staff to prevent bullying and promote inclusion. And here's some patient teaching. For nutrition and health, maintain a balanced diet, avoid excessive weight gain, which can strain joints and the spine. Encourage physical activity within safe limits. And hope in daily living, adapt living space, such as lowering counters, reachable light switches, and supportive bedding, and use adaptive equipment for independence in school, work, and play. For medication and therapy, teach about growth therapy if prescribed, and stress importance of consistent follow-ups in endocrinology and orthopedics. And to recognize complications, report breathing issues, chronic ear infections, spinal pain, or delayed development promptly. And lastly, psychosocial well-being. Encourage participation in normal childhood or adolescent activities, promote acceptance and advocacy, and connect family with dwarfism support networks, such as Little People of America.
Factors/causes leading to dwarfism. Achondroplasia occurs due to variants in the fibroblast growth factor receptor 3 gene, which is also FGFR3, which is a key aspect in regulating bone growth. It can occur spontaneously through this gene or be passed down from parent to child. Hypochondroplasia occurs through proteins that also become overactive and can't properly assist with bone growth and development in the FGFR3 gene. This can also be passed down genetically, but it can also occur even if there is no family history of the mutation. Pituitary dwarfism. This can occur due to the pituitary gland making too little growth hormone, or severe brain injury, or being born without a pituitary gland. This is also known as growth hormone deficiency. It can be present at birth or acquired later on in life. It can also be associated with lower levels of other hormones such as vasopressors, gonadotropins, or adrenocorticotropic hormones. Primordial dwarfism. This occurs due to severe growth restrictions that occur before birth, which are also called intrauterine growth restrictions. This type of dwarfism is extremely rare and only affects about 1 in every 3 million people. It can also occur due to abnormalities in the pericentrin gene or in the RNU4A-TAC gene, each of which have their own symptoms and manifestations associated with them. Gonadotrophic dwarfism. This occurs due to mutations that occur in the FGFR3 gene, which leads to severe disturbances in bone growth. This kind of mutation only occurs in 1 in every 20 to 30,000 people. Myths versus factors associated with dwarfism. Myth number 1, dwarfism is rare. Fact, in reality, over 200,000 people in the US have some form of dwarfism, making it more common than more people think it is. Myth number 2, people with dwarfism cannot lead normal lives. Fact, individuals with dwarfism live full and active lives, including working, attending school, and participating in recreational activities. Modifications may be needed in some cases, but it does not limit overall life potential. Myth number 3, dwarfism is a single condition. Fact, there are over 200 types of dwarfism and each have varying effects. While some people may experience mobility challenges, others may not experience any significant health issues. Myth number 4, dwarfism is caused by malnutrition or poor parenting. Fact, dwarfism is a genetic condition caused by specific gene mutations, not by environmental factors or parenting practices. Most cases are inherited, but some result from spontaneous genetic changes. Yay!